This presentation is adapted from Pulmonary, Sleep, Cardiology, and Critical Care Academy, an online CME-accredited course for advanced practitioners and physicians. So let's start with some basic definitions. We typically divide acute respiratory failure into three broad groups: acute hypoxemic, acute hypercapnic, and mixed acute respiratory failure. Acute hypoxemic respiratory failure is defined as the presence of severe arterial hypoxemia that is refractory to supplemental oxygen but with preserved ventilation that is either normocapnic or a PCO2 near the patient's baseline. Acute hypercapnic respiratory failure is defined as an elevated PCO2 and reflects an imbalance between CO2 production and elimination. The PCO2 in the blood is a ratio of how much CO2 is produced divided by how much is eliminated, so that either increased CO2 production or decreased elimination will raise the blood PCO2 level. Now, how do we eliminate CO2? Elimination of CO2 is proportionate to the alveolar ventilation. Alveolar ventilation is how much of the ventilation reaches the alveolar unit. The alveoli are very efficient in eliminating PCO2 as long as air reaches the alveolar units. Well, there are two main ways we can raise alveolar ventilation. We can increase the respiratory rate, or we can increase the tidal volume. So either of those, as we know, will increase CO2 elimination and lower the PCO2. But we have to remember that part of the tidal volume that we are delivering to the patient is what's called dead space, which we'll talk about in a few minutes. Dead space is the part of the tidal volume that does not participate in gas exchange, and there are really two types of dead space we'll get into: anatomic and physiologic. But for the purposes of understanding CO2 elimination, suffice it to say that we simply have to decrease the tidal volume by the dead space to understand how much the tidal volume is contributing to CO2 elimination. So for example, if our tidal volume is 500 cc's, but the dead space fraction is 200 cc's, then only the difference, or 300 cc's, is participating in CO2 elimination, so that an elevated dead space will decrease CO2 elimination. Now, we were talking a moment ago about increasing CO2 production. This can be caused by increasing metabolic demands, fevers, or change of nutritional substrate. For example, carbohydrates have a higher CO2 production per unit of oxygen consumption than fat or other substrates. Finally, decreased CO2 elimination can be caused by excessive load on the respiratory tract, severe lung disease, pump failure, which is when muscles such as the diaphragm or accessory muscles of ventilation fail, or the CO2 elimination can be decreased on a central mechanism such as central respiratory suppression. We see narcotic overdoses as a common mechanism of central respiratory suppression, leading to decreased CO2 elimination, which in turn will lead to a rising PCO2. Now, I mentioned that we do see patients with both hypoxemic and hypercapnic respiratory failure. These typically are the worst patients, and they are frequently requiring non-invasive ventilation or even intubation. Let's turn our attention to the initial evaluation of patients who were diagnosed with acute respiratory failure. First, we must assure an adequate airway, part of the ABCs. We can establish an oral or nasal airway, and if necessary, intubate the patient. Next, We need to address oxygenation relative to supplied oxygen. For example, if someone's on room air and their saturation is low, we'll obviously supply at least nasal cannula oxygen or possible escalate the oxygen delivery. If regular delivery doesn't help, we may decide to use high flow CPAP or BiPAP to help pressurize the oxygen and improve gas exchange based principally on alveolar recruitment. Now, how well our blood oxygenate depends principally on how high we can achieve an alveolar oxygen called P sub A, the alveolar oxygen, and it's a capital A because the arterial oxygen is a small a. The two main determinants of alveolar oxygen are the ambient FiO2, which on room air is 21% but can be raised with supplemental oxygen, and the atmospheric pressure, which at sea level is 760 millimeters of mercury, which is called 1 atmosphere. Now, even though these are the two main factors, we have to consider some corrections. First of all, we can obviously raise the FiO2 with supplemental oxygen. That will help raise alveolar oxygen. We have to remember that atmospheric pressure of 760 has to have a correction for the water vapor pressure, which is 47. So it's 760 minus 47 is how much space is available in the atmosphere to contain oxygen. That's obviously multiplied by the fraction of oxygen, which can range from 21% to 100%, depending on how much supplemental oxygen. Finally, the level of PCO2 in the alveoli inversely impacts the alveolar oxygen, so that as PCO2 rises, the P alveolar falls. Notice the minus sign right here. This is a consequence of the alveolar gas equation, but pure hypercapnic respiratory failure by necessity always lowers alveolar oxygen and causes hypoxia, even in the presence of healthy lungs. Now, once we have a sense of the alveolar oxygen tension, if we calculate that with this formula, we can actually calculate something called the arterial to alveolar gradient, the AA gradient. It's simply the alveolar oxygen minus the arterial oxygen. For example, on room air at sea level, a healthy person might have an alveolar oxygen of 100 and an arterial of 85. And in that case, 100 minus 85 is an AA gradient of 15, which is pretty normal. When we have people on high FiO2, the alveolar oxygen might be 300 and the arterial might only be 60. And then we would say the arterial to alveolar gradient of 240 is elevated. Now, this equation that I showed you a minute ago can simplify on room air at sea level, because on room air we know FiO2 is 0.21, and at sea level we can put in 760 and 47 for the atmospheric and water pressure respectively. So this entire fraction here, or the entire product of FiO2, P atmosphere minus P water, simplifies to 150. So for example, on room air at sea level, if your PCO2 is 40, then the alveolar is 100. That's 150 minus 40 divided by 0.8. That comes to 100. And that's what I was saying a minute ago. On room air, a regular healthy person should have an alveolar of 100 when their PCO2 is 40. And that's why when their PO2 in room air is 85, their AA gradient is 15. Now, our target with treating patients should not be a completely perfect PO2, but an acceptable PO2. We tend to target PO2s in the 60 to 70 range, which should achieve a saturation over 90%. After going higher on PO2, there's only a modest further change in the saturation. The saturation can only go as high as 100%. So we're very happy when the PO2 is in the 60s or 70s and the saturations are over 90%. So our next part of initial evaluation and management of patient with acute hypoxic is to support ventilation. We can use bag valve ventilation if necessary, non-invasive ventilation, or even a ventilator if they are intubated. Our target should be a PCO2 to achieve a pH of 7.35 to 7.4. Now that in a normal person could be a normal PCO2 or a slightly higher PCO2, but not every patient needs to have PCO2s near normal. I'm going to show you 3 exceptions to when we're not necessarily targeting a PCO2 of 40 to 45. First of all, if a patient has a primary respiratory alkalosis, we may not be able to target this pH. The pH may be elevated from the primary respiratory alkalosis, let's say 7.5, and their PCO2 may be 32. And if a patient's primarily hyperventilating, there's nothing we can do. We just have to allow them to have a high pH and a relatively low PCO2. There's really no good way to target a higher PCO2 short of heavily sedating or paralyzing the patient. Another time we have a different goal of PCO2 is in a chronically hypercapnic patient. We don't need to target a normal PCO2 of 40 to 45. We can target their baseline PCO2, which might be 60 or 70. That will typically still keep their pH close to normal, about 7.3 to 7.4. And the third time we don't target a PCO2 of 40 to 45 is if we're using a permissive hypercapnic strategy. We're going to go over that when we talk about management of ARDS. But in permissive hypercapnia, we have no choice but to allow the PCO to remain elevated, let's say 60 or 70, even if that's a low pH as low as about 7.2. Other considerations in the initial evaluation and management of patients with acute respiratory failure include establishing vascular access, almost always intravenous access and possibly arterial access, obtaining an ABG and possible VBGs to help us to distinguish whether there's pure acute hypercapnia. That would be an elevated PCO2 without a base excess. That is, the kidneys have not had time to accumulate bicarbonate to compensate the hypercapnia. Another pattern we might see on an ABG or VBG is acute on chronic hypercapnia. That is, there's some base excess, but still a low pH, indicating that there hasn't been enough time to completely compensate. Finally, there could be chronic hypercapnia where there's enough time to accumulate a base excess through renal mechanisms to close to normalize the pH. So these blood gases help us understand the state of compensation for hypercapnia. They also give us an accurate reading on the oxygen level and saturations independent of what we can tell from oximetry, which is sometimes inaccurate. Other modalities that we may lean on at the time of initial evaluation of a patient with acute respiratory failure are the physical examination. That can be very helpful. We might hear wheezing, discern crackles at the lung bases, look for edema, jugular venous distension, lots of things we can see on exam that might help us understand the mechanism of acute respiratory failure. We, of course, obtain imaging. Virtually all people, as you know, that are having respiratory failure have a chest x-ray, and some have CT scans of the chest and other specialized imaging, such as a VQ scan or another image to help understand the mechanism of respiratory failure. I like to review the waveforms on the mechanical ventilator. They give me a lot of information about the mechanism of respiratory failure. The expiratory flow pattern is very helpful in looking for airflow obstruction. A prolonged expiratory flow, especially flow that is still present at the end of expiration, almost always shows airflow obstruction. I also like to look at the waveforms to calculate lung mechanics. I'm going to show you in the ventilator talk how we can use a plateau pressure at end inspiration to help us calculate the lung compliance, which is a measure of how stiff the lung is, and the lung resistance, which shows how much airflow obstruction there might be. This is very helpful on patients who are on mechanical ventilation. If you'd like to learn more, please visit our educational center at pulmonaryandsleepacademy.com, where we have 70 hours of self-paced online CME-accredited courses covering pulmonary, sleep, cardiology, and critical care medicine. Please enjoy more of our short visits on our PSA YouTube channel. You can purchase our full courses with an exclusive 10% discount code using YouTube10.